Parizat hasn't come in, right? Parul has, Jyotika, Meena has. Doctor, both the doctors are in today.
मला तुला दाखवायची नाही बुद्धी अंग काय
She said, Parizat said she would be joining. Let's see if Shiri said she's going to try coming in. Shanti,
Yes.
you are going to do that kidney function. You're going to do a presentation
But I may not be able to do it in June, July.
in.
June, July, I may not be able to.
But when can you do it?
Ending of July or August.
I think because we are going to start with the sixth series somewhere mid-May, right?
What
Which
are you
will
starting with? I didn't get you.
the sixth series.
Yes.
We'll start by mid-May, mid to end May. Sorry, and if you can make it, otherwise we'll get it later. I'm trying to get Jaldeep also, but I'm not able to get him. I want him to do the skills and effective communication. But anyway, let us see. We can bring them in later.
Anyway, I'll get back to you if I can do it this month.
Aji,
I'll get back to you if I can do it this
please,
month.
please, please, please. Because I do have a kidney function presentation in the sixth series, but that's very basic. I'm sure you can give us more stuff. You know. What is the time now?
4 o'clock.
Parizat should come in. Has she come in?
Yeah.
Parizat is coming. I think, what's her name? Nazni is not going to come in today. She is 2 days. She's taken off, going off somewhere, and I don't know about Shelly. Rohina hasn't come in yet.
Yeah.
Rohina said she will try to get in because she has a class, or she'll follow the YouTube. So you've got still 2 more minutes. Hmm?
Yeah.
So let's put the presentation on. Okay, so this is the first slide. Therapeutic drug monitoring, TDM as we call it. And it's, it's quite interesting, something very different. That these are the regular drugs which one takes, and how much should they take and how much should they not take, because it's got a certain value. It's got a therapeutic value. Anything in that value is going to work. Anything above that and below that will not work. So let's go with the first slide. Okay, so history is the science of therapeutic drug monitoring, TDM as we call it, grew out of the recognition that certain drugs have a narrow therapeutic range. In concentrations above the upper limit of the range, the drug can be toxic. In concentrations below the lower limit of the range, the drug can be ineffective. So that is, it's got a very narrow range. You can't take too much, you can't take too little. Not all patients have the same response at similar doses. Studies have been initiated to determine the clinical value of TDM testing, and in certain instances, clear clinical value was demonstrated. Today, there are over 20 therapeutic drugs which are routinely monitored, and we'll see what types are monitored. Okay. So what is this monitoring? Therapeutic drug monitoring is the measurement of specific drugs at timed intervals in order to maintain the relatively constant concentrations of the medication in the bloodstream. Drugs that are monitored tend to have narrow therapeutic index. The blood level required to be effective is close to the level that causes significant side effects and toxicity. For some drugs, maintaining the steady state is not as simple as giving the standard dose of medication. Each person will absorb, metabolize, utilize, and eliminate drugs at different rates based upon the age, general state of health, genetic makeup, and the interference of other medications that they are taking. These rates may change over time and vary from day to day. Changes in that rate may also occur in various diseases states or through interaction with other medications. So it's a very narrow range, and there are certain parameters that you would have to follow, taking into consideration the patient's age, sex, and all that. So a relatively new field, therapeutic drug monitoring, is a measurement of specific drugs at intervals in order to maintain a relatively constant concentration of the medication in the bloodstream. It is used to measure the level of certain medications in the blood to determine the most suitable dose and to avoid toxic results. Okay? And let's take a look at these drugs. What are they and why we have to monitor them so closely? Current indicators help establish the criteria used to determine if a particular drug therapy could be monitored simply via clinical response, or if the TDM testing is indeed needed. Toxicity can manifest clinically in a way that is very similar to the underlying disease. In these cases, the value of TDM is discovering drug toxicity before irreparable harm is done. I told you can't have too much, you can't have too little. In order for some drugs to be effective and non-toxic, TDM testing is required to ensure the patient maintains a concentration of drug within the symptoms and is within the established therapeutic range. This remains the essential underlying value of TDM testing for both the clinician and the patient. Okay. What are these? What required and what is important? Drug efficacy, difficult to establish clinically. Phenytoin is one. Suspected toxicity, inadequate therapeutic response, compliance concerns, dosage change in patient's clinical state, change in co-medication, quinidine decreases the digoxin clearance, manifestation of toxicity and disease states are similar, like in theophylline. So a couple of drugs are mentioned here and how important they are. Not very important. Toxicity is not a realistic concern like in penicillin. Effects can be measured using functional laboratory tests. Anticoagulants. Plasma concentration is not predictably related to effects, again with anticoagulants. Effects of the relationship remain undefined. Antidepressants. So here you have anticoagulants which can affect your clotting time, etc. And you've got these antidepressants with people having problems. Okay. Factors that affect results. Many factors contribute to the production of an acute and meaningful drug level measurement. Pharmacokinetics, pharmacodynamics. So we need to know what these two are. Dose, sampling time, and type of testing, methodology, and genetic polymorphism. These factors are to be considered. Major source of pharmacokinetics, variability, patient compliance, lack of age, neonates, children, elderly, physiology, gender, pregnancy, disease, hepatic, renal, cardiovascular, respiratory diseases, drug-to-drug interaction, environmental influences. Pharmacokinetic variability describes the relationship between the dose administered and the resulting plasma concentration. This relationship can be affected by differences in a way a patient's system absorbs, distributes, metabolizes, and or eliminates the drug. In other words, one dose does not fit all. Pharmacokinetic variability can be greatly reduced by adjusting doses to maintain plasma drug concentration within a therapeutic range. So for each patient or each person, it is different. Now you've got pharmacodynamics variability. Describes the way in which drug affects the body function and the relationship between the drug's chemical structure, actions and effects. Sampling time is also critical since the drug concentration varies over the entire dosing interval and with duration of dosing in relation to achieving steady state. Through values, those obtained just prior to dosing are the least variable concentrations and most often used to establish therapeutic ranges. Drugs with short half-lives in relationship to dosing intervals requires thorough concentration monitoring, there's a mistake here. Drugs with long half-life can be monitored at any point in the dosage interval. So drugs with half-lives which are, I think, short half-lives in relation to dosing interval require thorough concentration monitoring. Drugs with long half-life can be monitored at any point in the dosage interval. So these two we have to take into consideration. All right. Factors that affect interpretation. What's happening? Huh? What happened? Why did this come in? Are we on this?
Yeah,
Sorry, there was an interruption, guys. Put it on now. Okay. Factors that affect interpretations. What are you doing?
My screen is not sharing.
Factors that affect result interpretation vary from drug to drug. For example, a digoxin concentration must be interpreted in the light of the creatinine and potassium concentrations, the presence of acidosis or the administration of interacting drugs as well as the patient's clinical state. When determining the appropriate lithium dose or interpreting lithium results, knowing if a woman pregnant is a key, as dose requirement increases due to increased renal clearance. So all these factors have to be taken into consideration. Commonly monitored drugs, this should be interesting. So you've got protein binding. TDM assays typically require serum or plasma and usually measure both the bound and unbound drug. Even though it is unbound, the drug that reacts with the receptor to produce a response. This is seldom an issue unless the patient's binding capacity is altered due to disease state, drug interaction, and non-linear binding. In such cases, the effect of protein binding needs to be taken into consideration when interpreting the result. Okay. Therapeutic ranges, are they important? And the answer is yes. Measuring the blood concentrations of certain therapeutic drugs is only one aspect of effective TDM monitoring. Because the therapeutic ranges are not absolute, in many instances, expert clinical interpretation of the value is necessary to derive meaning from the result. True TDM testing takes into consideration all the factors that affect drug results, as well as all the factors that can affect interpretation as described below. So commonly monitored drugs. There are several classes of drugs commonly monitored to ensure correct blood concentrations, including the following. So you've got the anti-epileptics, antiarrhythmics, antibiotics, antineoplastics, antimanics, bronchodilators, and immunosuppressants. So quite a few, and these are very routinely used nowadays. There's nothing new, okay? So anti-epileptic monitoring is critical. Carbamazepine, Tegretol, ethoxypyrimidine, phenobarbital, phenytoin, valproic acid. These are some common names. When to monitor and why? Soon after steady state conditions are initially expected, when the patient is seizure free and experiencing no adverse effects, determines therapeutic concentration. When question is to overdose to determine the cause of relapse. Before and after any change in dose, before and after introducing a drug that may interact. So here you have to be very careful with people who have epileptic seizures. I'll give you one case which I have in the house. My 10-year-old pup, she was 8 at that time. She licked some rat poison on the floor below, and she came and she had an epileptic fit, which scared the hell out of me. It was a Saturday evening. A vet was not available at that time. Anyway, it lasted about 30 seconds, and I took her on a Monday for a complete checkup, and doctor was quite happy with her, but she was put on a certain drug which is quite expensive, which had to be monitored twice a day. And I've used this over a period of time. She has had 4 or 5 epileptic seizures after that, but recently, touch wood, for the past 6-7 months, she's clear. And it's what we are using on her is a compound, and she's done pretty well with it. We haven't had a need to monitor dosage because she's taking it in the right proportion, depending on the weight. The only thing it did was, she was a very thin little skinny dog. This dog now eats and eats and eats and eats, and she put on weight. From 16 kilos, she has gone on to 20 kilos. But that's her, right? Then you've got therapeutic ranges for anti-epileptic drugs should be used to help determine the optimal therapeutic concentrations for an individual patient, as one patient's optimal therapeutic concentration may fall into the toxic range, while another may fall below the established therapeutic range. Applications of therapeutic range for anti-epileptic therapies guide treatment before the clinical response has had time to become clear, determine the cause of treatment failure, aid in the diagnosis of symptoms that may represent drug overdoses. So with anti-epileptics, you have to be very, very careful. So we've got the antiarrhythmic drug cases used to improve cardiac concentrations in congestive heart failure and to correct supraventricular tachycardia. Used to improve cardiac contractions in congestive heart failure and to correct prevent ventricular tachycardia. So where you're using something for the heart, you have to be very careful. Digitoxin, digoxin, dispropanide, lidocaine, and NAPA, and all these are test timing is important. For all antiarrhythmic drugs, samples should be collected at least 6 hours, preferably 8 post-dose, to allow for absorption and distribution. Therapeutic ranges for patients with normal renal function who have achieved steady state levels. The therapeutic range for digoxin is based on the blood sample obtained 8 hours after the last dose. Testing of early samples may produce falsely elevated results. A lot of factors to be considered by the doctor. Drug indication therapeutic range used to treat different types of bacterial infections. Most often used to treat severe infections of multi-drug resistant gram-negative bacteria given to patients with potentially life-threatening infections. So here you have amikacin, gentamicin, neclamycin, tobramycin, vancomycin. So where the therapeutic range is concerned, there are established ranges for through and peak concentrations during traditional amyloglycoside therapy. However, there are no established ranges for one daily testing dosage, as the accumulation is not yet an issue and the efficacy of the dose is well established. So you have to be careful about these drugs also for bacterial infections. So we've got anti-manic drug indications. Therapeutic range used to treat bipolar disorders and to supplement other antidepressants. So you've got the drug dosage, you've got the peak, where like your lithium is it's a very small range, 0.6 to 1.2 millimoles per liter. So when a person is bipolar, I think you all know the meaning of bipolar, something going a little off with their mental functions. Anti-neoplastics. So anti-neuroplastic drug indication therapeutic range used in the treatment of neoplast disorders. Methotrox, the peak is 0.1 to 260 micromoles per liter. It's a wide range. Then you've got the bronchodilators. Theophylline is one of the most commonly used bronchodilators. It is primarily used to treat patients with chronic asthma. Monitoring is necessary due to drugs highly variable in inter-individual pharmacokinetics, drug indications and therapeutic range. For use in quantitative analysis of caffeine levels in human serum, in subjects undergoing therapy with caffeine, especially in cases of neonatal apnea, used to relax smooth muscles in bronchi and pulmonary blood vessels. The peak is 1 to 30 mg per ml, 10 to 20 mg per ml of caffeine and theophylline. So these are the inhalers which one uses for problems with the chest, bronchodilators. Then you've got the immunosuppressants, cyclosporin, Neurals, Sandy-Immune, and you've got all these fancy names on top. TDM testing is critical aspect of immunosuppressive drug therapy. Optimizing drug dosing is not only key to avoiding rejection, but also in reducing the severe side effects of these drugs, like infections, cancer, weight gain, hypertension, and possible liver and kidney failure, which often prompts patients for non-compliance. The strategy is to employ a combination of drugs in doses that prevent acute rejection and loss of graft function without compromising overall health. Transplant patients are prescribed immunosuppressive drugs as lifelong maintenance therapy, and most drugs are routinely monitored. Okay, that's my dog. So to sum it up, TDM testing is used in patient's care to ensure the patient achieves the maximum therapeutic effect in the shortest amount of time, minimize the risk of drug toxicity, and identify which drug is appropriate for diagnosis. The four categories of pharmacokinetics include distribution, absorption, excretion, and metabolism. Drug administration is commonly administered orally or intramuscularly or IM, subcutaneously, rectally, transdermal, and intravenous IVs. It is impossible to draw the blood right before the dose is administered, and the right again before the next dose is administered. So pharmacology concepts, PK and PD. So pharmacokinetics, PK, what the total does to a drug. What the body does to the drug. So this could be absorption, distribution, metabolism and excretion. And in dynamics PD, what drug does to the body. Key terms: AUC, area under the curve, that is the total drug concentrations. C, minimum drug level in 24 hours. IC, inhibitory concentrations, that is concentration of drug required to inhibit viral replications by an X factor. TDM methodologies for estimation: you can use HPLC, GC-MS, LC-MS, liquid chromatography, mass spectroscopy, RIA not used now, Patinia, an immunoturbidimetric method that is used today for TDM testing is Patinia, or particle enhanced turbidimetric inhibition, immunoassay. Then you've got the EIA, you've got EMIT. The EMIT is your enzyme multiplied immunoassay technique. FPIA, fluorescent polarization immunoassay, chemiluminescence. Then you've got ACMIA, affinity chrome mediated immunoassay. And you've got CDIA, clone enzyme donor immunoassay. So all these methods can be used on various machines. So we say health is not simply the absence of sickness and say no to drugs, but then when you have a certain problem, you have to be on these drugs. And if you're on these drugs, you have to monitor. That is about it, guys. Any questions or anything you would like to add?
Ma'am,
Yes.
if we take a particular concentration of the drug and we are taking only half the amount, the concentration is still that. So if it's like 500 micrograms of some drug and we take half of it, half a tablet or half, it's still 500 micrograms. But then how does that work? How does that
But why do you take half? You recommended to take half?
No, supposing this is just a hypothetical situation where people may just take half of it. Then what?
Then you may not have the whole effect of the drug. Or if your body is used to that half thing, then continue. But I think if you're taking one of those different types of drugs, then I think you should be monitored.
Yeah, but then the concentration is still the same. It's just that the quantity. That's what I was trying to say. The quantity would be.
No, but Parul, if you're taking half the tablet,
Yes, half a tablet. Supposing it's a simple paracetamol, half a tablet. It's still 500 mg. And how it's
but
rested.
if it suits you for something like paracetamol, I would continue. I wouldn't bother about it much. Shanti, Dr. Chogle, what do you say? Unmute. Can't hear you. Dr. Chogle.
Ma'am, you need to unmute yourself.
Unmute, please. Dr. Chogle, unmute. Unmute. All right.
Can you hear me now?
Yes.
Yes. Sorry for the interruption. I would like to tell one of the case which happened with me with my father. It was only 2003, 2004. He got lot of cough. He had fever, lot of cough, and then he went to his regular cardiologist. Okay, so he said this cough can be due to some chest infection. I said okay. So he said that he gave expectorants which didn't resolve the situation. That cough was persistent. Then he gave some antibiotics also, which also didn't do the needful. After that, he is telling me that we will have a CT scan and an X-ray. The CT scan he said that there must be some chest infection which is underlying and we have to sort it out. Now, when I was working in British Candy that time, and I had one Dr. Armighty contractor as my friend who was, now she is a consultant, who was an intensivist under Dr. Farooq Gwadia. So I was a very good friend of mine. So she said, you show me the X-ray. I said, okay. Then the next day I took the X-ray and showed it to her. She said that this appears as if it is a proper cardiac failure. Why is telling you to do a chest CT scan and all that? 100% there is no chest infection. This X-ray is completely white, and this shows that this is a typical pulmonary edema. शुभा तो ऐसे कर, उसको छोटा सा डोज क्लासिक्स का दे दे, and you ask him, because that cardiologist was her teacher in Nair Hospital. So she said that don't tell him who has said, but you do one 2D echo. Now it didn't strike to this person, I do not know how. And as she said, I told him, shall we do one 2D echo? Then he called us to that Santa Cruz, now I forgot the name of that diagnostic center. And we went there, we did a 2D echo, and to our surprise, the 2D echo showed only ejection fraction of 30%. That was the reason for his cough. After that, he's telling, oh, it is, the ejection fraction is very poor. Means he kept on beating about the bush with a CT scan and all that. So a proper treatment, a proper diagnostic menu should be taken for this ruling out such kind of things. And then he started with digoxin. Now, if you would permit me, is digoxin and creatinine, as you said, that the monitoring of digoxin has to be done in light of creatinine. So now, after he started with that digoxin, there's also a very small range. It should not exceed more than 2 units. So that dose was maintained and he started feeling much better. The cough was reduced, it absolutely was resolved, and as per Dr. Armighty, we were also giving him Lasix, and Lasix and digoxin helped him instead of monitoring an antibiotic and theophylline. He started him on a treatment with theophylline, theobid, and that didn't help him at all. So how drugs are effective to find out the right reason and the right treatment. So I would tell you this digoxin and creatinine. Creatinine has to be done when digoxin is monitored, because what happens is that if the creatinine, if there is a low clearance, then what happens due to the raised creatinine, the digoxin retains in the blood and it causes digoxin toxicity. So creatinine has to be seen first. If the creatinine, if the renal clearance is not good, then the creatinine rises and the raised creatinine in the blood raises the digoxin and it causes digoxin toxicity. Another thing is that if there is a low potassium, hypokalemia, what happens is when there is a hypokalemia, the potassium actually tries to get attached to the cardiac tissues. When it gets attached to the cardiac tissues, the clearance decreases, and what happens is from hypokalemia it goes up to hyperkalemia. So the acidosis. Now, how is the relation is if there is a low potassium, the pH is more. So this attachment goes to the cardiac tissues when the pH is more, and when it goes down, the potassium, when it rises, the pH goes down. So that is where that acidosis thing you said, na? That is so the creatinine and potassium have to be desperately taken into consideration when digoxin is to be monitored. And the interpretation was very nice, as you said, that a minimum and maximum levels have to be considered, because if the dose is minimum, it becomes ineffective. The drug becomes ineffective, and if the dose is maximum, it crosses the maximum level, it affects the patient. That is, the toxicity sets in, where the patient starts getting nausea, vomiting, arrhythmia, and then headache, giddiness, all that. So the drug monitoring is very useful, a very nice topic which the technicians should understand. Why the drug monitoring, therapeutic drug monitoring is very essential before starting a particular drug. And as you rightly said, a steady state has to be maintained, because once you start the dose, once you start the drug, you have to attain a steady state. That point also was very nicely referred, where you said that 8 hours gap for a digoxin value has to be seen, because in case if the sample is taken prior to 8 hours, means after giving the drug, 8 hours have to be considered. The timing is very important, because if the digoxin levels are tried to be considered, it will give you falsely elevated values, because the drug metabolization, clearance, everything is important. The dosage is important, the age is important, the underlying disease is important, whether the patient is having a hepatic disease or whether the patient is having renal disease. That is very, very, very important. Means where we see whether the patient is having raised creatinine, whether the patient is having ups and downs in his potassium level. And another thing is that the steady state is very necessary, and the levels have to be considered when the toxicity is not there and when the minimum dose also is not there, because ineffectiveness and toxicity is very important. Age also is very important. Whether the patient has got any underlying disease also is important. So as you rightly said, the dosage, the sampling, the utilization, the metabolization, and the renal clearance, all these 5 factors are very, very important. A nice presentation, a very subtle and a nice presentation for the technicians of these days to understand. Thank you. Thanks for considering me as one of the opinion leaders. Thank you very much.
Thank you, Dr. Shobha. We've kept it very simple. I didn't want to go into too many details of therapeutic drugs. I've kept it at TDM monitoring, which is very important, especially if you're working in the lab.
Yes.
Shanti, anything to add? Dr. Shanti?
No, I have nothing to add.
Anything in your experience?
No,
Anything in your experience?
so much of therapeutic drug monitoring, but we do a lot of transplant drugs like cyclosporine, tacrolimus.
Yes.
Now the timing of these samples is very important, and when you monitor regularly for follow-up, there has to be either the trough value or the peak value. Some surgeons want a peak value, some surgeons want a trough value. So it is very important that one individual follows the same pattern, and usually it is always better, like as in other tests, that they do it in the same lab unless occasionally to cross-check. Because when they go from lab to lab, there are a lot of variations, and methodologies are different, instrumentations are different, normative reference intervals are different. So, especially for these immunosuppressant drugs, we have to be very careful how we monitor. Yes, digoxin and all are very critical, and usually these patients have creatinine done because they are coming into the hospital, so as a basic test, creatinine done. And if you have therapeutic drug monitoring in the lab, it should be a 24-hour affair because for drugs like digoxin and all, we should be able to immediately inform because of the toxicity it can cause. That is my limited experience, but most of the time we do mainly cyclosporin and tacrolimus, and we actually were doing a whole battery of drugs, but the problem is we don't get so many samples, and therefore it doesn't work out economically viable for any lab to do so many drugs.
Okay, that's interesting. Two different examples. One to go with cardiac and one to go with the immunosuppressives.
Drug level and this thing is very important, peak levels.
Parul, you understood? So your paracetamol is quite safe.
No, I just wanted to know if you are taking half the.
But why do you want to take half?
No, supposing somebody takes it, it's still the. I just want to, just for general knowledge, it's still the concentration is the same. It's the quantity which is less. That's what I was trying to. Okay.
Okay. Anybody else?
In your statement, I think there's a little confusion in your statement. What do you mean by concentration and quantity?
No, ma'am. So if supposing it's a paracetamol of 500 mg, I'm taking half the tablet. That half tablet still has 500 mg.
No,
Oh,
250.
it will have 250.
250.
The whole 500 mg is in the whole tablet.
It's in the whole tablet. Yes,
Yeah.
ma'am.
So if you're taking half of it, you will not be taking 500.
you're taking half the concentration.
No, I think your question, I'm not able to understand completely. It is like taking, I'll give you an example. We'll say a Cadbury's chocolate. Okay, the Cadbury's chocolate contains so many calories. Okay, now if you're taking, say, a bug, you're taking a bit of it, you're not consuming all the calories that the chocolate has.
Yes, ma'am. But the sweetness. Supposing you're talking of the sugar in the Cadbury.
The sugar also is distributed along that whole length of
Yes,
the
it's distributed, but in that one piece, the amount of sugar, I'm getting confused with that.
Yes, yes, I understand.
Okay, sir.
Think over your question and get that next week in answer.
Yes, ma'am.
Can I speak, Parul? My father-in-law had epilepsy, so he was taking a drug called Dilantin, and same drug, same amount, he was prescribing continued for a few months. After a few months, he started feeling drowsy, and when he showed it to the doctor, he said that this drug has to be maintained level of Dilantin at that point in your blood. That is the concentration which is there. So you may be taking the same half a tablet also, but in your blood levels, what is the level of that substance? That is what you will determine. So even if you're taking that one tablet, is it your blood? Is it enough? Is it less? Or is it more for your problem which you are taking? Maybe some person, even the same person at a certain point of time, that same drug, same amount will be at a good appropriate level, and at a certain time it may be an excess or low. That's why we monitor the drug to make sure that it hasn't gone higher than what is expected, or it's giving the required effect. Your same the concentration may be the same point of time, same quantity also, but your blood at what level is it having? That is what you check.
Okay.
I don't know if I could explain that.
Yes. Now I'm thinking, yes, that's one better. Thank you.
All right. Anybody else? Can we end now?
Yes, ma'am.
Yes,
Thank you
yes.
so much.
All right. We have HbA1c next Thursday. It's
Okay.
HbA1c, guys. Okay. I know we've touched upon it briefly with diabetes. Let's go back to it again because it's a very routine test and it tells you a lot about the person. I was so happy yesterday when I got my value of 6. I've always kept a 6, and I thank God the results are normal. I keep a 6. I started off with 10 some years back, and I'm keeping a steady 6. So I was just telling Munira that acha, now with these results I can go face Dr. Snehala Sheikh and tell her that my results are fine. I haven't been to her for the past 2-3 years, and I keep sending, I'm coming, and I think with these results I can go see her. She's a very dear friend of mine, and I think she's a wonderful doctor, and she is from my school and Sophia College before she went into medicine, and I'm so glad I'm with her. Murira was yelling at me, you haven't had your test done, blah blah blah. And touch wood, yesterday the tests were all acceptable. All right?
Thank you, ma'am.
Okay.
Yes, ma'am.
We shall see
Thank
you.
you so much, ma'am.
We shall see
Thank
you
you.
next
Thank you.
Thursday. And Shanti, please do attend.
Yes, yes.
Don't disappear and work on your kidney thing.
Yeah, I've already seen.
Okie dokie. God bless. See ya.
Thank you, ma'am.
See ya.
Please take care, ma'am.
See ya.
Yeah.
Bye.
Bye.